Welcome back to our deep dive on the bedside examination of the dizzy patient. This is the third and final part.
All right, this is it, the final installment where we're going to pull everything together. We're moving beyond the specific maneuvers into the systemic examination. We'll hit orthostatic vitals, the focused neurological screen, and, maybe most importantly, how to synthesize those red flags into a clear, defensible referral decision. This is where the rubber meets the road.
Let's just start with a fact that, honestly, should change how we all approach our older, dizzy patients. In folks on multiple medications, orthostatic hypotension isn't just common. It's actually more likely than a vestibular problem. And yet, it's the thing we most often miss. This isn't just some random statistic. It's a huge call to action for all of us. So here's our game plan. We're going to unpack orthostatic vitals, then move to the focused neuro exam. After that, we'll get into decoding those critical red flags, and finally, we'll map out some really clear referral pathways. Let's get into it. Okay, let's dive into this. We're starting with orthostatic blood pressure. You know, it's a simple 3-minute test you can do at any bedside. And believe me, it has a surprisingly high diagnostic yield. Now, the procedure itself seems pretty straightforward, but the secret sauce is the timing. It is absolutely critical for accuracy. So after 5 minutes lying down, you're going to measure at 1 minute and 3 minutes standing. And here's a key tip. If you have any suspicion of a delayed drop, don't stop there. Keep going to 5 minutes. And why are we banging this drum so hard? Well, because the payoff is massive. For patients who come in saying they just feel lightheaded, this simple test has a diagnostic yield of 20 to 30%. I mean, think about that for a second. Up to a third of your cases could be cracked just by doing this one simple thing. That's an incredible return on your clinical investment. Now, here's where it gets really interesting. This table just beautifully breaks down the different orthostatic syndromes. See, it's not just about a drop in blood pressure. You have to look at the patterns. Is the heart rate jumping up like you'd expect, or is it just sitting there? That could suggest a neurogenic cause. Or does the heart rate just go through the roof without a big BP drop? Well, then you might be looking at POTS. Interpreting these details is where the real diagnostic magic happens. All right, next up, we're going to sharpen our focus with a neurological screen. And look, this isn't about doing a full, exhaustive exam on everyone. This is a targeted hunt for those subtle signs that point to a central posterior circulation problem. This is just brilliant. It really shows the power of a targeted examination. We're not just doing a vague neuro exam. We're looking for specific signs that are like anatomical signposts. A brand new unilateral hearing loss, that points you right to the AICA territory. Limb ataxia that's way out of proportion to their vertigo, that screams cerebellar hemisphere lesion. Every single sign here gives you a clue to the location, turning your assessment into a powerful localization tool right at the bedside. Now, we're getting to what is arguably the most critical part of this entire series, identifying the red flags that demand you act immediately. This is all about knowing when to stop reassuring the patient and start escalating their care. This next point, it's a fundamental shift in how we need to think diagnostically. We're all taught the rule of parsimony, right? Find the one single diagnosis that explains everything. Well, as it says right here, that rule is dangerously unreliable when it comes to posterior circulation stroke. You just can't afford to wait for all the puzzle pieces to fit perfectly. So, what's the crucial takeaway? It's this. One subtle sign is enough. Direction-changing nystagmus, a little skew deviation, even mild truncal ataxia. If you see that, even if the rest of the exam is totally normal, that is sufficient evidence of a central cause until proven otherwise. Please, do not wait for more signs to pop up to confirm your suspicion. And this right here, this might be the single most important message for clinical safety in this entire series. If your findings are ambiguous, not clearly peripheral, but not definitively central either, that is your finding. That uncertainty is the trigger. Like it says, equivocal findings are a reason to escalate, not a reason to reassure. So, we've identified the red flags. Now what? Let's translate that knowledge into action with some clear referral pathways. Knowing exactly when to pick up the phone is just as critical a skill as any physical exam technique. So, when is that call absolutely necessary? Well, first, if you've done a great, structured exam and you're still scratching your head, time to refer. Second, if you've got what looks like BPV, but it's just not behaving, it's resistant to treatment or has weird features like downbeating nystagmus, that's a huge red flag. And finally, things like progressive hearing loss or chronic symptoms Always warrant a specialist opinion. And hey, when you do make that referral, meticulous documentation is your best friend. It makes communication crystal clear, and it's essential for medical legal reasons. Be specific. Write down the character of the nystagmus, the head impulse result for each side, the skew, the positional findings, the orthostatics, the gait. You're painting a clear picture for the next clinician in line. Okay, so let's quickly recap the 3 absolute game changers from this session. 1, never ever skip the lying standing BP. Its diagnostic yield is just way too high to ignore. 2, let the history guide you to a targeted exam. It's faster and it's more accurate. And 3, the golden rule for safety. If you're not sure, you refer. Uncertainty means referral, not reassurance. And that brings our 3-part series to a close. From that first 60 seconds of just watching the patient walk, through the power of the hints exam and positional maneuvers, all the way to orthostatics and red flags, you now have a comprehensive toolkit. A structured examination, tailored to what the patient's story tells you, is going to change or confirm your diagnosis in more than 80% of cases. The whole goal of this series was to build your confidence and your competence right there at the bedside. So, based on everything we've covered, what's the one subtle sign you're going to be looking for more closely in your very next dizzy patient? To keep learning about dizziness, vertigo, and imbalance, please visit our website. And hey, if you found this series valuable, we'd be so grateful if you'd subscribe and leave a rating. It really helps other clinicians find this material. Thanks so much for joining us.